Namaste and greetings from the World Health Organization. My name is Chandra-Mouli and I lead the work on adolescent sexual and reproductive health and rights in WHO. In this presentation, I'm going to present a global overview on safe abortion care in adolescents. This slide contains a number of relevant definitions. Induced abortion is the intentional loss of an intrauterine pregnancy due to medical or surgical means. Safe abortion is abortion which meets the three criteria listed in para 2. It's done with a method recommended by WHO. It is appropriate to the duration of the pregnancy and is provided by and supported by a trained healthcare provider. The third one is less safe abortion. You'll see there's a distinction between less safe abortion and least safe abortion. Less safe abortion is abortion that is done by a trained health worker, but with an outdated method, for example, sharp curettage. Or it is done using a WHO recommended method, but by someone who is not trained and registered to provide that service. The fourth one is the least safe form of abortion, which is provided by individuals who are untrained and unregistered and unskilled using dangerous methods, for example, caustic substances. This slide is one of two slides which provides the rationale for attention to the provision of safe abortion care. It makes 2 points. The first is that unsafe abortion is an important problem. An estimated 5.7 million girls aged 15 to 19 undergo abortions every year in low and middle income countries, the majority of which are unsafe. Secondly, unsafe abortions in adolescents have substantial consequences because unlike older women, adolescents tend to seek abortions late, tend to try to use methods on their own, so self-induced, and to seek help from untrained providers. They're also unaware of where to seek help and what their rights are and what the law is. They often fear that the law is more restrictive than it is. This is the second slide in the section on rationale. It makes the point that safe abortion care carries low health risks. And it notes that the risks differ based on the duration of the pregnancy, on the method used, on the person providing the service. But overall, it is much lower in terms of consequences than carrying a pregnancy to term in general, but especially in a young person. The fourth point in rationale, and the second on this slide, is that abortion-related laws and policies, procedures, the provision of good quality care needs attention. So there are legal, policy, procedural restrictions, and even when service is legally allowed, it is not provided. And there are horror stories in some places of adolescents being punished by health workers because they should not have got pregnant in the first place. In the previous two slides, I spoke about the rationale, pointing to the needs. This slide speaks to the rights. States are obliged under human rights law to provide safe abortion care. Implementation of measures to prevent unsafe abortion and to provide post-abortion care are part of the core obligations to uphold the right to sexual and reproductive health and to survive. States are obliged to ensure universal access to a comprehensive package of sexual and reproductive health interventions, including safe abortion care and post-abortion care, and the latter, whether or not abortion is legal in the country. Human rights mechanisms have called for the decriminalization of abortion and removal of legal, policy, and procedural barriers such as third-party consent requirements. Now, the denial of abortion and the forced continuation of pregnancy have been identified as a form of gender-based violence. This slide lists three key concepts to consider. It lists three problems in blue, and then actions that could be taken to address these problems. Let me highlight the three problems. Restrictive laws and policies often force adolescents to seek illegal and unsafe abortions. Actions must be taken to address this as listed in the slide. Similarly, adolescents are less likely than adult women to obtain safe abortion services for a number of reasons, and the actions to try to address this are listed on this slide. And thirdly, abortion services and healthcare providers are often not adolescent friendly. Again, the actions to be taken are listed here, and this needs to go beyond training and the delivery of guidelines to building capacity and positive attitudes and holding health workers accountable for their actions. This slide lists the WHO guidelines which address abortion. I'm not going to read out them all. They're all available in the public arena and from WHO's website free of charge. And they're also available from the organizers of the course, Geneva Foundation for Medical Education and Research. Suffice to say that WHO publishes and updates its guidelines regularly based on the best evidence that is available, as well as programmatic experience from around the world, with a particular emphasis on low and middle income countries. WHO's guidelines are a particular category of documents which are, if you like, WHO's flagship publications. Complementary to those guidelines, we have a number of WHO publications listed on the slide, as well as publications by other organizations and journal publications. We have included a selection of those in this document. And again, all of them are available from the Geneva Foundation on request. This is one of two slides that deals with responding to the safe abortion care needs of adolescents in the context of COVID-19. WHO published a technical brief titled Not on Pause with UNFPA, and the section on abortion contains the recommendations listed on this and the next slide. The first one relates to informing adolescents about how to access services within the framework of the law. Second is to ensure that in health facilities the care is available for adolescents and is provided respectfully and confidentially. Third is a suggestion to relax policies to enable telemedicine to be used to provide services, particularly medical abortion services, to avoid people coming into facilities. And the fourth one is to reduce barriers to the provision and the use of services, including waiving restrictions and providing services free of charge. The points made in the previous slide continue. Here, the points made are that we need to ensure that gender-based violence care is available, sexually transmitted infection services are available, and post-abortion contraception is available. To make sure that these services are provided either on the spot or through linkages in the easiest possible way from the perspective of the adolescents. We've always said in our discussions that COVID-19 is a huge threat, but it also represents an important opportunity. And if these good practices, which we are learning from a number of countries, can be institutionalized and maintained into the future, that's at least some good things we can take away from the COVID-19 pandemic. This is the last slide in the global segment of the presentation. Here you see a conversation between a group of girls, young women, who are sharing their own needs, their fears, and there is finally at the bottom of these conversation bubbles a reassuring message from one of the participants in this conversation that things have changed. So that's the world that we are all working towards. With that, I thank you, and we complete the global segment of this presentation, and I'll hand over the baton to my regional colleague to give you an overview of the regional perspective. Many thanks.
Greetings everyone, and welcome to the second half of Module 4 on safe abortion care, which examines the issue of abortion from the perspective of the Eastern Mediterranean region. Most of you have already met me. My name is Shatha Elnakib, and I work with the WHO Eastern Mediterranean Office. I want to start by reading the statement on the slide to you because it summarizes WHO's stance on abortion. According to WHO, access to legal, safe, and comprehensive abortion care, including post-abortion care, is essential for the attainment of the highest possible level of sexual and reproductive health. So we're going to use this as a point of departure moving forward. First, I'd like to start by giving you a sense of the magnitude of abortions in the region. And this is from a Lancet article that used statistical modeling in order to estimate the regional distribution of abortions by safety categories. The WHO regional classifications were not used here. Instead, World Bank regions or groups were used. The closest EMR estimates are represented by two regions, Western Asia and Northern Africa. And we see here that together, Northern Africa and Western Asia had almost 4 million abortions taking place. In Western Asia, half of these abortions were safe and the other half were classified as unsafe abortions. In Northern Africa, a staggering 71% of abortions are unsafe. The EMR has a highly restrictive legal and policy environment with regards to abortion, even though the last slide shows us that abortions increasingly take place in the region. In 2019, WHO conducted a RMNCH policy survey in which 16 member countries from the region took part. Despite the restrictive legal environment, the report found that 11 out of 16 countries included abortion as a component of their national reproductive health care policy. 15 out of 16 countries included abortion supplies and equipment in their national commodities list, and 6 countries included contraception and post-abortion care. So this slide shows the World Abortion Laws Map, which is a map that depicts the legal status of abortion in countries across the globe, and it is actually updated in real time. The map basically categorizes the legal status of abortion in countries across the globe using a coloring scheme that goes from red to blue, with red indicating severe restrictiveness and blue indicating relative liberal stance towards abortion. And as you can see, the EMR is mostly red or yellow, signifying a highly restrictive legal environment. This is a table taken from a UNFPA report that looks at legal grounds under which abortion can be permitted in Arab countries. And we see here from the table that none of the countries actually allow abortion based on request, except for Tunisia. Tunisia is the only exception. Most of the countries do not allow abortion in cases of rape or incest. Only a few allow it for mental health and physical health reasons. And you see also that most of the countries, with the exception of Comoros, Djibouti, and Mauritania, allow abortions when there is, in fact, a threat to the life of the woman. Comoros, Djibouti, and Mauritania are actually 3 countries that do not allow abortion on any legal grounds. All Arab countries, regardless of their law, require authorization of 1 or more doctors before an abortion can be done. And actually, we know that in countries where there are highly restrictive laws and policies on abortion, reproductive health outcomes are actually worse. So this is showcasing estimates of 3 reproductive outcomes, 3 indicators of reproductive health, and we see that they're consistently worse in countries that have restrictive laws and policies on abortion. We know that these countries often have higher average rate of unsafe abortion compared to countries with liberal laws or policies that are permissive of abortion. We also see that the rate of maternal death is higher. The fertility rate in adolescents tends to also be higher in countries with restrictive policies. There are several barriers that impede adolescents' access to safe abortion care in the region. I'm going to outline some of these barriers. So one of them is lack of data. Most countries in the region do not collect data on abortion. They do not have any official statistics that indicate how many abortions take place or what's the magnitude of abortions. And this is especially true of official statistics among marginalized women. So not only do we not have statistics in general, we also lack statistics on the most vulnerable groups like unmarried women, adolescent girls, women with disability. We also know that there are several formidable barriers to accessing services. So we know that there's lack of infrastructure, cost is a big barrier, adolescents often fear breaches in confidentiality. There's also fear among women with unregistered marriages that they cannot access safe abortion services and lack of information generally on abortion care. Also, we've already covered this, there's a highly restrictive legal and policy environment in abortion, which prevents women, and particularly adolescent girls who are often more vulnerable, from accessing safe abortion care and pushes them to seek unsafe abortion services from non-medical providers. And this is there was an Iranian study that showed that 1/3 or 33% of abortions in their sample actually took place, were performed by non-medical providers. And then obviously there's a lot of stigma associated with abortion, and there's an erroneous belief that if a country were to improve access to safe abortion services, then the abortion rate will increase. And we know that that's not the case. We know from Tunisia's experience that making abortion increasingly available did not increase the abortion rate in the country on the long run. There's also lack of political commitment because abortion is such a highly polarizing issue, and so politicians often shy away from engaging in efforts to expand the access to safe abortion among women. We also have a serious issue with lack of availability of service providers and lack of adolescent-friendly services, which discourage many adolescent girls from seeking safe abortion care. And obviously, humanitarian settings, because of political conflicts, the various political conflicts and turmoil in the region, adolescents are particularly vulnerable to unplanned pregnancy, and thus they often have an increased need for abortion services. And we're going to touch upon abortion humanitarian settings in a few slides. Now I would like to focus on a case study that looked at abortion in the West Bank, particularly in Hebron Governorate in southern West Bank in Palestine. So this was a study that used mixed methods, both quantitative and qualitative methods, to understand the scale and practices around abortion among a sample of women. So this was conducted by Palestinian Family Planning and Protection Association, PFPPA. And what they did is that they surveyed a total of 540 women who were attending their clinics. And these were clinics located at 4 urban and rural sites. These were not really selected using random sampling, so it's not entirely a random sample of women, but it does give us some insight into the magnitude of abortion. What did they find? So interestingly, they found that more than 70% of survey respondents had an abortion at least once in their lifetime. 2/3, or 66% of women who ever had an abortion had more than one abortion. They also asked women who knew about their abortion before it took place and where and who conducted the abortion. And they found that the majority of women did not tell anyone that they were having an abortion. Almost 70% said that nobody at all had prior knowledge about the abortion. 20% only said that their husband knew. Only 4% said their husband and mother-in-law knew. 7.5% said their husband, mother-in-law, or their own mother knew. And 1% said only close friend knew. So the majority do not tell anyone that they were having an abortion. As when asked who did the abortion or where the abortion took place, 40% or a little bit over 40% said that they did it at a health center or hospital by a doctor, but then the rest said it was either done by a DEA or a doctor in his private clinic, or 31% actually said they did it themselves at home. So abortion is actually a very important issue in humanitarian settings, and there's increasing recognition globally that we need to address abortion in our SRH programs and humanitarian settings. However, abortion services are rarely provided. And why is abortion an issue in the first place in humanitarian settings? And this is a very interesting paper written by my professor, Dr. McGinn and Sarah Casey. So I encourage you to read it. And this is basically making the case for why abortion should be addressed in humanitarian settings. And there are three main points that they make in the paper. One is that sexual violence and rape often increase in humanitarian crisis. We know that to be the case, and so the need for abortion is heightened. We know that access to contraception may be disrupted or may be limited, and so women may experience unintended or unwanted pregnancies. And we've seen from Module 2 in the case study of Yemen that there were contraceptive stockouts that lasted for months at a time, and so women did not have access to contraception. In these kinds of settings, abortion care is important. And we also, the third point that they make is that women who experience unwanted pregnancies and do not have access to them will often resort to unsafe abortions, right? They will get the abortion, they will just get it in an unsafe way. And adolescents in particular in humanitarian settings are at an increased risk for unintended pregnancy. We know that to be the case because of existing gender and social power dynamics. We know that adolescents are at higher risk of sexual violence and coercion, and we know that traditional or cultural values often prevent adolescents from accessing SRH information and services. And so they are actually at higher risk of unintended pregnancy. And because they lack awareness of contraceptive methods, because they often have impeded access to contraceptive methods, they are likely to experience unwanted pregnancy. We also know that adolescents are more likely than adults to seek unsafe abortions or to wait longer to seek abortion care because of fear of breaches in confidentiality, fear of stigma, because of policy constraints that prevent provision of SRH services to adolescents, because of structural barriers such as transportation issues or delays in knowing that they are actually pregnant. So we know that this is an important issue, and it's particularly important for adolescents. I want to touch upon two innovative approaches to abortion that can be implemented in the region. And the first one is related to self-care interventions, and WHO has produced guidance on this. So self-care interventions are evidence-based quality drugs or medicines or devices or diagnostics, any kinds of products that can be provided fully or partially outside of the formal health system. And so using self-care can actually bring about a shift towards combating stigma and privacy challenges by removing the need for a healthcare provider to be involved in the provision of abortion. The second opportunity is digital technology, and we've increasingly been using digital technology in the provision of health services in the COVID pandemic. So using digital technologies to provide abortion care and services can give an opportunity for adolescents to receive the support and the counseling that they need, and even abortion care itself. Now I would like to present two initiatives from the region that have addressed abortion and that have shown great success. And the first regional initiative is implemented by Mary Stopes International in Afghanistan. Mary Stopes, or MSI, is an NGO in Afghanistan that provides family planning services and post-abortion care, and it's actually one of the largest providers of these services in the country. And the aim of this intervention was to ensure that no abortion takes place that is unsafe, and that every individual who wants to access contraception can get it, can access it. And so to accomplish this, they provided services to women and girls without discrimination. They tried to work towards removing legal and policy barriers and stigma in the provision of services. They ensured that women and girls are sensitized to their legal rights and entitlements, and that the care that they were that women were able to access affordable care, and that they were actually involved in the decision around the method that they use and the health service provider who gives them the method. So Mary Stopes is actually present in 30 cities. They operate 36 centers in the country, and these centers offer a comprehensive range of services, including contraception and post-abortion care. And they also use outreach services through what they call Mary Stopes ladies. So they had 40 Mary Stopes ladies and 10 mobile outreach teams that would bring services closer to women and girls who were living in urban slums and other hard-to-reach areas. And this project was so successful that it averted 156,000 unsafe abortions and prevented 286,000 unintended pregnancies. So these are some specific initiatives that were conducted by Mary Stopes International in Afghanistan. And the first one is the Integrated Reproductive and Maternal Health Project, which was a project that aimed to improve the availability, accessibility, quality, and acceptability of SRH services, and particularly for groups who are vulnerable or marginalized. And this was a project that took place in 6 provinces of the country. The second initiative is very interesting. It is a campaign to address stigma against abortion. It's called the Smash Abortion Stigma Campaign. And the campaign aimed to increase community acceptance for SRH services by working with religious leaders and their wives and other stakeholders as well. But it's so interesting that in 2015, 30% of clients were actually referred through religious leaders or their wives. The third initiative pertains to the response to COVID-19, and basically the NGO worked with partners to ensure that contraception, safe abortion, and post-abortion care are defined by the government as essential services, and so that they're available in the basic package of services. These are some interesting initiatives, but it would also be interesting to learn how this work has been impacted by the recent Taliban's rise to power. So maybe this is something that we can discuss in the Google Forum. The second initiative is by IPAS. So this is an NGO in Pakistan. It's actually the only international organization in the country that provides access to abortion and contraception, or is focused on expanding access to abortion and contraception. And the aim of this specific initiative that we're featuring here was to engage with the government of Pakistan to stimulate norm change, and particularly political norm change on abortion, through using maternal mortality as an entry point. So the 3 approaches that they used were an advocacy campaign. Basically, they hosted meetings with key provincial stakeholders to discuss the impact unsafe abortion has on women and girls, and to identify solutions for mitigating this impact. And so basically the advocacy took place for the use of WHO's latest guidelines on uterine evacuation. They also established coordinating committees in the country to help galvanize momentum on abortion and using these technologies. And they also supported these committees to include misoprostol. So this is a medication that's used for abortion, and manual vacuum aspiration in the essential package of health services, and essential lists is the reproductive health technology of choice for providing safe abortion and post-abortion care. And because of these efforts, the Department of Health in Punjab procured 10 million misoprostol pills from the government's budget by 2015. Other approaches that they used are task shifting, or the redistribution of tasks, and particularly from highly qualified providers to providers with shorter training. So what they did in this case was they trained mid-level providers in abortion and post-abortion care. They also worked to increase the quality of services by developing service delivery standards and guidelines. And they also spotlighted the situation in the global human rights arena. So basically, they presented some of the challenges that Pakistani women face in UN fora, and basically galvanized support for the service delivery standards and guidelines for high quality safe uterine evacuation among the MOH and the government. This slide and the next one outline some of the lessons learned from the regional initiatives on the provision of safe abortion services. I invite you to read the bullet points on these 2 slides. I'm not going to go over them. With this, we will finish Module 4, and next week we're going to have a webinar where we can discuss some of these issues in real time. I hope you found this presentation thought-provoking, and I look forward to our discussion.